Welcome, everyone. We're trickling in slowly. It's very nice to have you all here. My name's Crystal from the 2020 Mom Team, and we are excited to have you join us for our topic networking session on ACEs. I will let your hosts introduce themselves momentarily, let you all know that you are welcome to use the Zoom chat here to ask questions, respond to questions, and share any thoughts you have as we go along. We will be monitoring the chat and look forward to having a discussion after Brenda and Sarah's presentation. So ladies, I will turn it over to you. Thank you very much for being here with us today.
Yes, thank you very much, Crystal. Hello, everybody. Sarah and I are so excited to be with you and to have this time to have this discussion that we are both very passionate about. We are going to take a minute and introduce ourselves, and we would ask that everybody who's here, if you could drop in the chat your name and where you are geographically located and what the name of your organization is. That would be great. And if you want to add what it is that you do with your organization, that would be wonderful too. So I'm going to start us off and then I'm going to turn it over to Sarah. I'm going to introduce myself. So Sarah, you want to move to the next slide? So my name is Brenda Blassingame. I am an independent social sector consultant. I've been that for about a year now. And what's important for you all to know about me is that I have been working in the early childhood space for over 2 decades. I've been working in public health spaces for over 3 decades. And I am, what I bring to my work is a very strong conviction and lens of equity, justice, diversity, and inclusion, and liberation. So all the work that I do is really from that point of view. I've worked at the local level, the state level, the national level. I've worked in public government. I've worked in nonprofits, and I've also worked in philanthropy. So I have a view of early childhood systems building and work around maternal child health from a lot of different vantage points. And I'm glad to be here with you today and have this conversation. I'll turn it over to you, Sarah.
Okay. Hi, everyone. Thank you, Brenda. Excited to be here with you. My name is Sarah Johnson. I am an OBGYN physician in Northern California in the East Bay at La Clínica de la Raza, which is a community health center in Oakland. And I am very passionate about trauma-informed care, both because of the, kind of metabolizing the learnings that we heard from Dr. Perry about, that science is learning about the effects of biography on biology and how I see that play out in my patients' experiences. And it's also been a very meaningful path for me to be on in terms of my own personal journey and growth. So I've been able to do a lot of implementation and quality improvement projects in my clinic, and then have also worked as an advisor to some statewide organizations in the field. And what we want to do today is a brief presentation. We're just going to talk for about 10 minutes to kind of frame the conversation. And I'm really excited to have our two complementary perspectives. I bring a little bit more of a clinical lens, and then as Brenda described, more of a structural liberation. I love that, having that word in their lens. And I think these are complementary, and we want the group to think deeply about kind of how we frame this, the key concepts, think about the relevance of addressing adversity and trauma in perinatal and maternity settings, think about resilience too, and think about how we think about it. And we want to connect with each other to hear ideas and reflect on challenges. And we hope everyone's going to leave with a deeper understanding and feeling empowered to take some kind of action, whether that's big or small. So I'll give a little kind of clinical lens to this. Brenda will share some of her frame, and then we'll all talk as a group. Okay, we wanted to start with a level set just with definitions that are important to ground any shared conversation. So this one of trauma comes from SAMHSA, and you guys may all be familiar. I love this definition of trauma because it has these 3 E's there in blue. So it's not just an event, which might or might not be experienced by any particular person as traumatic. So an event itself isn't a trauma, but it's the experience that the individual has, and something that's traumatic to you, I might not think is traumatic, or vice versa. So an event or series of an events experienced as emotionally overwhelming or life-threatening with lasting adverse effects. So the event, the experience, and the effects. And important to remember, the effects are holistic. It's not just, oh, trauma, mental health, but really all of the mind and body systems, emotional, psychological, spiritual, and physical well-being that are affected by trauma. Here is a definition of resilience that we liked, and this is from the American Psychological Association. And we want to just put a pin in the idea that there's different nuances to many different definitions of resilience. And this one has a key theme in most definitions that involves flexibility and adjustment, and to internal and external demands in response to difficult or challenging life experiences. But we're going to double click more on the resilience concept in a moment. So what I'm going to share in the next few slides comes from my participation in a stakeholder group through the California Maternal Quality Care Collaborative, starting in the fall of 21 and ongoing. And kind of demonstrating that our field is not in the phase, as Dr. Perry noted yesterday, where the information is being ignored. We're no longer ignoring this in our field, which I think is demonstrated by the fact that a big quality improvement in maternity care powerhouse, CMQCC, decided to take this on. And so many stakeholders met over several months to kind of grapple with these questions of how should we metabolize the emerging science and understanding of how trauma affects health in OB practice. I'm going to share with you a few key points from that. At the end of this deck, if you want to look later, there are some more concrete recommendations that the group came up with, and then our full findings are going to be published in the OBGYN Journal Obstetrics and Gynecology in June. So keep an eye out for that, and I think it'll be helpful. I thought so. Okay, so some key things to think about when we're imagining addressing adversity and trauma in the context of perinatal care. One thing is, trauma is highly salient in this context. So, sorry, I got distracted. Okay. So past experiences of stress and trauma are highly salient during the perinatal period, and reminders and stressful moments can trigger trauma responses that might have been dormant or not around, things like hyperarousal or dissociation. And past experiences, a whole range of them, for example, sexual assault, childhood abuse, and relationship challenges, but also things that aren't on that ACE questionnaire, like prior healthcare experiences or immigration trauma or trauma that's historical in nature, might come up for people. And in this context of prenatal care, when people are experiencing changes in their identity, in their body, and their relationships, and invasive exams, and all kinds of new demands on their system, this is something that is very clear that we really need to be present to and create trauma-informed care that's sensitive and responsive to these experiences. So that's one thing. This is coming up for people. This is a big deal in this developmental moment. Okay, so this image has to do with how we think about stressors, and felt important for our stakeholder group to name after we started to dive into the literature, which is something we do in medicine when we're trying to figure out how to translate science into clinical practice. If you go into the literature, you might feel like you want your head to explode, because all of the studies are trying to disentangle the statistical effects of one stressor versus another, and one study's controlling for these 5 things and another study's controlling for different things, and how do you compare? The high level conclusion from that, though, is that these stressors are all entangled. Like, this is a web of stressors that manifests over time and continues to ensnare people. And maybe we want to disentangle them for statistical learning, but the life experience is of entangled stressors. And these might be temporally different. So like early childhood sexual abuse, for example, is related to a higher risk later on of intimate partner violence, which is something that we're asking people about in clinic, but not usually about the earlier piece, right? But sometimes the stressors don't have that chronicity. Sometimes they may be persistent and pervasive, things like racism and discrimination. So there's different timing, there's different impacts at different developmental phases, but this is really an interconnected, tangled web of stressors rather than one discrete thing. And when we have that web of stressors, we can start to put this into a more life course or developmental model. And this image is an attempt, a start of that. I think we could do better making it life course and developmental, but this is emphasizing the medical and biological complications. So we're seeing how this web of stressors gets under the skin. Here we're using the term weathering, which is used in perinatal literature to refer to the early deterioration of health that results from the impact of stressors on body systems. And here it's resulting in physical and mental and behavioral health conditions, and can also directly result in adverse perinatal and infant outcomes. And with mental health being our focus here, I will say that in the literature, the most robust associations between early adversity and perinatal outcomes are revealed in the area of mental health. Okay, so we have a web of stressors getting under the skin and into our biology and showing up in conditions that we are treating clinically. And when we have this developmental frame, we also can have such an important piece of the equation, which is protective and resilience factors that show how throughout the life course, there are opportunities to mitigate and buffer and heal the effects of trauma. It's not destiny, okay? But let's double click briefly on that resilience concept. Okay, this first quote here says, it matters that we continue to have a conversation about resilience, because the meta message is that the experience of trauma doesn't only yield pathology. Okay. If we don't talk about resilience, we're just telling sort of a doom and gloom story that's not accurate about the human experience and obscures so many opportunities, including clinical opportunities, to really provide support and healing and shift health trajectories. Okay. The second quote reflects exasperation with a way that resilience is often conceived of in our culture, which is that we're supposed to sort of be heroic and overcome everything despite a systemic setup that's really goes against that. And that came up yesterday in the story that the first presenter told about having postpartum depression triggered when there was no support around her postpartum. And this quote here refers specifically to the Black experience, the experience of Black and Brown women who are so often praised for being resilient, when really it's systems and structures that exist in that resilience, and that our attention should be at the system and structural level rather than just saying, keep being more resilient. So that makes us think, like, what's the definition of resilience that we want? And I think the definition that we want is really an ecological definition, where we are including systems and structures and communities of support that provide support and ease for patients, rather than just asking them to do everything on their own. Okay, so I will hand it over to Brenda, and then we'll talk as a group.
Great. So I'm here today really as a gentle disruptor to invite us to expand our thinking. This is a role that I've been playing pretty much my whole career, but now I'm really taking it on and embracing this role. I want us to think about the nuances, things that are not always explicit, interactions, interplays, intersections between circumstances and context. I want us to apply a lens of equity, justice, and liberation in this work. We have to think about and work on equity and justice so that we can get to liberation, because liberation is what will free us all. And so I want to talk just a little bit about ACES. As you all see, this is a picture of ACES. ACES did something important over the last couple of decades. It was evidence that adverse and negative experiences from a person's childhood can and does have an effect on health and well-being of that person as an adult over their life course. Many of us knew this from our work in and with children, families, and communities, and then ACES, through research and science, proved it. So we got the evidence base that we needed. If we can go to the next slide, please. How we tend to view adverse experiences is through a lens of individuality. So the slide we just saw was more of what happens to the individual. We don't think about these things usually through a collective lens, yet for many of us, adverse experiences are experienced collectively as a result of community environments that are filled with adversity. ACEs can and do lead to trauma, but not all adversity leads to trauma. We have recognized the impact of trauma on people, and we've embraced trauma-informed care in schools and in much of the work that we do, which encourages support and treatment to the whole person rather than focusing on only treating individual symptoms or specific behaviors. But if we only think about the individual adversities that we just saw without thinking about these adversities that we're looking at right now, which are addressing systemic and institutional and community environments, we're not getting the full picture. So can we go to the next slide? We have to think about, what does it mean to live in these adverse community environments that are the root of the disparities and the inequities that we're seeing in different aspects of life, including pregnancy and birthing. We have to consider the community and societal adversities and how the combination of those adversities with individual adversities, how they intersect and play with each other, quote unquote, and how there's a cumulative effect. So that gets back to the piece that Sarah was just saying about the weathering, right? So then the next slide. When we view through a lens of intergenerational historical trauma and community context and environment together, it looks like this. Before we get to those individual ACEs, there are two other foundational pieces in place. What I'm asking us to do is to think about how ACEs are on top of these other two levels of adversity and trauma. Something different is happening for people of color with adversity and trauma, which means we have to think differently about how we support and work with individuals, with families, with children, with communities. And we have to really think differently how we work during this very sensitive time, which is during pregnancy and birthing and immediately postpartum. If we could go to the last slide, the next slide, the last slide for me. I want to talk a little bit about resilience. So this slide is really showing what can community resilience look like? What sort of, I hold this as, if we could envision how we would look different, this is what this slide is about. And I want to talk about resilience, which we saw the definition at the beginning about resilience, and we saw two examples of that, one that was more individual and one that was more ecological. And what I want to say is that when we think about resilience as the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands, we have to think about that not as an individual having flexibility, but what does it mean when resilience is a multi-layered and complex concept, particularly for Black, Brown, and Indigenous folks? We have generations of trauma, systemic racism, and cultural barriers that lead to resilience, looking very different than what we have taken it to mean in our society for the most part. For some people, there's no choice but to be resilient. Ijimoma Madubata is a clinical psychologist and a doctoral candidate at the University of Houston, and she says it's crucial to validate how harmful chronic exposure to race-based stressors is for African Americans, even when they do exhibit resilience. And that's reflecting back again to the comment that Sarah made earlier about how Black women are seen as so resilient. And I want to end by saying this is about the water that we swim in. In the Water of Systems Change that was developed by FSG, there's this comment about a fish swimming up to another fish and saying, "How's the water feeling today?" And the other fish looks at that fish and goes, "Water? What water?" That what we have to realize, it's the water we swim in, it's the air that we breathe, and we have to look at the individual as well as the ecological context. The interconnectedness of wider social circumstances and adverse experiences within the family environment. And in maternal care, this is why everyone needs to be aware of weathering in Black and Brown women. And the weathering, that's the accumulation of racial stress over Black women's lives and how it contributes to the observed pattern of racial disparities and maternal health and birth outcomes that we're seeing. So much of our work is abstract and iterative and calls for our attention and intention to the nuances, things that are not always explicit, interactions, interplays, and intersections around all of these things. And if we're not unpacking it, looking at things and being conscious about this in our work, we will do things the way we have always done them. And as they say, if you do what you've always done, you will get what you've always gotten. And what we have always gotten is not acceptable, and we need to do something different. Okay, we can go to the next slide now, Sarah.
Let's see. So we're going to have a discussion next, and we really want to hear what everyone's thinking. And we'd love if you are comfortable and in a position where you can turn on your camera. And we want to hear from everyone. A few reminders before we enter any discussion: share and listen from the heart and speak from your own experience. We say learning leaves and the specifics stay here. So I think that speaks for itself, but we don't want to share any personal information that people share with us today. And then listen with compassion and empathy to experiences that aren't reflective of your own, and be curious. So we wanted to set those as some baseline agreements for our discussion. And we want to talk to you about your reactions to what we said, what you're thinking about this topic, and kind of work together through these questions. Considering this combination of liberation and medical perspectives, what would support truly transformative relationships in clinical practice? And I can see in the chat when people introduce themselves, it looks like many people here do kind of directly interface with patients and clients. So, what would make these interactions that you have, and including around this topic, instead of transactional, here's a form, fill it out, what would help make it transformative? And so what do we already have in place that can serve our vision, and what do we need to build? So I'm going to stop sharing, and then if you want to look at this later, you'll see some more information about trauma-informed care. But we'd love to open this up to discussion and think through together what successful trauma-informed perinatal care would look like, either, both from sort of an individual clinical lens and a broader structural and systems lens. And if we, what we need, what we can already use, how we can build this together. It doesn't exist yet, so we need to build it together.
So we want to invite you again to come on camera so we can see each other if you're willing to do that. And also please use the chat to put in thoughts, comments, questions, all those things too.
Is anyone, it's kind of awkward and weird to be the first person to talk in a large Zoom room. Is anyone willing to share, even just like tell us who you are, what's a reaction, what are you bringing to this conversation, why'd you join? And
I'd love to hear, I want to add on to what Sarah just said, like what's resonating with you from what we said, what's not resonating.
For sure.
Oh, I see some people coming on camera. Thank you.
Hi guys, I'm Susan. I'm a home visitor with the Marine Corps' new parent support program, and we have some wonderful resources available to offer support to service members and their families. Participation is sometimes hard to, we know how wonderful, what a benefit it would be. For instance, something as simple as play morning, an opportunity for parents of very young children to gather in an unstructured environment and just watch the little ones play and meet other parents. Great sense of community. But I offer it and people don't always, there are some people that participate, but the number of people that you offer it to is often lower than who participates. So how do we get people to participate Or what is it? Because I recognize how hard it is for some people to even consider participating in groups or support groups. I've even heard when I suggest postpartum support groups, people will even say, "Oh yeah, I don't do groups. That doesn't work at all for me." And I don't know how to encourage participation. I don't know. That's just my thoughts on that.
I love that. I mean, let's let that sit there, I think. It sounds like you have it's great to have wonderful services. I think that that's often a barrier to even starting to talk about this. And then I think something else that I'm noticing come up in your comments is that people have ways of being in the world that often reflect that may reflect their prior experiences. So we have to trust them with what feels right.
Yes.
But I have found at times the possibility of transformative conversations through almost like a clinical discussion about adversity and its effects, kind of helping people see that what happened to you, not what's wrong with you lens. Who else? Thank you so much for that. I want to check out the resources too. Who else would like to share thoughts or ideas?
Let me take a minute and
please.
respond, Susan.
Yeah.
I think that sometimes in a lot of cultures, coming and talking about issues or problems or what you're struggling with in a group is not something that you've been encouraged to do. So I would even wonder if it's possible to, you know, engage with some of the parents themselves and have them lead smaller gatherings and groups. Like instead of everybody coming together, thinking about, well, maybe there's a group that does want to be together, and maybe that group is based off of the age of their kids. Maybe it's based off of other mothers, other parents that look like them, and how you might be able to, instead of inviting everybody to be together in a group, that you may create smaller groups and then do some large group activities, but give smaller groups so that people might feel more comfortable being in a group of only, 2, 3, or 4 other parents.
I'll just say one tiny thing too, because what Brenda and I were both getting at and what you're getting at is safety, basically.
Yeah.
And when you look at sort of like all of the, each individual of us is going to have our own new questions, because this is kind of uncharted territory. And I love SAMHSA's 6 principles. The first one is safety, because every time you're trying to figure out what should I do in this novel situation, if you go back, you just that's the first one, how do I create safety? So it might even just be as simple as asking clients, what would feel safe to you, and how can we make it feel safe? And for someone, it might be being in an enclosed environment, or for someone, it might be having other people look at them, but exploring with patients to expand their capacity to name what would make them safe, and then working with them to build it. And using those principles, because boy, are there a million novel situations that we have to navigate here.
Thank you. Yeah.
Well, and Sarah, just in response to what you just said, I'd add the thought about, depending on where your group is located, sometimes going outside is a really great option. So if it's something where people can be outside, and if you have nice weather, people can also gauge the safety that they feel of the group by walking by and not having to go into an enclosed space and introduce themselves. Especially if it sounds like you've got a casual sort of layout to the timing. So it should be a low stress situation to walk into, and something like outside in a park can be very inviting that way.
In the context of a favorable community environment where there's a safe, healthy park. Yeah, totally. Thank you, Crystal.
Yeah. Other thoughts, comments?
Challenging scenarios. I really appreciated that Susan shared almost like a troubleshooting thing for everyone.
Just
Are
pull
you-
from
yeah,
the
go ahead.
chat here for
Please.
you. So Luz is sharing from Texas that time constraints and capacity are often barriers to better serve families. Insurance reimbursement or cost for these services has been difficult to obtain for many of our communities. And she's in Texas, unable to have camera microphone, but wanted to share that in the chat for your response and reflection.
Yeah, it is really unfortunate that both in prenatal care and well child visits that the time is so short, because those are two particular contexts where we really want to meet people where they are. We really want to give them the time and the opportunity to talk about what's on their mind and what's going on. And so often, as the practitioner, as the clinician, you're having to race through a number of different things that you have to go through. And sometimes I think that, that is about if there's a way to engage people before they even get in to the room with you. Like I was just on something the other day where people said that the person that somebody most trusted wasn't the doctor they were going in to see, it was the receptionist at the front desk that greeted them and talked to them when they came in.
Mhm.
So even thinking about how you create an environment that allows more connection than possibly can happen once you are in the room doing the clinical piece of the work.
Yeah, I think actually that's such a wonderful point. There's actually research that the connectedness felt with team members such as office greeters or medical assistants really influences people's willingness to disclose sensitive information once they get in the room with a clinician. So, I mean, just what you said. And I also think, I think the financing, that's an important issue that's challenging, but often, at least in sort of my prenatal practice where it's similar, like time constraint, I have found that there is sometimes enough room for like enough of an insight or the seed of a conversation that later becomes transformative. And then working with colleagues, we've started to imagine our resources as things that we can deploy in response to people's traumatic stress. And they're not perfect, but they're better than some. So someone like home, for example, home visiting programs, which I think many of them are national, or behavioral health services, or any kind of group if people want to be in groups, or just being outside, exploring with people kind of, and this is where this resilience and strengths frame is so key. What's going well for you, what makes you feel good, what's making you connected. Let's talk about supporting that. Maybe it's through a program or service, or maybe it's just through brainstorming with you. And they can be small conversations that plant seeds and later come up. And I think for me, at least, just showing an open-hearted willingness to address the question, to have the question of what's happened to you in your life exist in the room, has resulted in people disclosing things that have really impacted their care. Like, I don't want to birth in this position because of an experience during childhood sexual abuse. That's like a really important thing for me as a doctor to know. That's not for a social worker. I mean, I want their help. But like as a clinician, there's a real salience to my clinical role. So I think, and I've actually found the ACE screen piece of paper with a welcoming letter that we have in my clinic, though I don't love it for its transactional nature, in the context of a 15-minute visit with its description and introducing it in a safe way, it has at times been really helpful for me to have almost like a more quick pin in this topic, and then it can open a door. Not perfect though. Kimberly Price, do you want to share kind of, I see your comments in the chat. Would you, if you want to, do you want to share some of your thoughts or your context? Oh, you're muted, if that's you. Oh, there you go. Or if someone else wants to share while Kimberly's fixing her audio.
No.
Oh, there you are.
There it is.
Yeah.
Yep.
Yeah.
Okay. So I have so many thoughts about this, partnering with people, meeting people where they are, not minimizing what they've been through or what their perceptions are. And working as a case manager in an emergency department really made me realize how empowering it is to build people up with their own potential, like in their own knowledge. Like oftentimes patients wouldn't ask the doctor, well, how come you're doing an MRI and not doing a CAT scan? But they would ask me. And I'd say, well, that's a great question for the doctor. Oh, well, I didn't think we could ask him questions. So just having that conversation that really empowers them when somebody believes that you believe in them, it's transformative. And I feel like when it happens in a community setting, a friend group setting, any kind of setting, there's going to be a domino effect. And I think it's just like, that's my vision, that's my dream of just really transforming people in believing in themselves and advocating for themselves and just I feel oftentimes that people focus on what's wrong with them. Like, I have diabetes, I'm broken, I'm flawed. I have high blood pressure, I'm broken, I'm flawed. And I feel like when you partner with them, when you really connect with them, you can kind of move their perspective more on well, there's nothing wrong with you. We just need to figure out, let's set some goals to figure out how we're going to lower your blood pressure, how we're going to lower your blood sugar. And I think that in itself just transforms them to take the focus, because everybody, a lot of times we think there's something wrong with us. We're flawed in some area of our life, and we're not. It's just getting something to get that focus off.
Yeah, I think, like Kimberly, what I really love about what you're saying is it is more about creating the context for people to see their own agency and their own self-determination and their own power. And so often we are reduced in our society to a label. And I'm doing this, I'm in this 9-month program that's looking at somatic abolitionism. And one of the things that the leader says repeatedly, and when he first said it, it was like so new to me that I was like, what? And now when I hear him say it, it really does calm me down. He says, you are not defective. You were being protective of yourself, not defective, protective. That so many of us have had to do things to protect ourselves, that we're not in touch with our own power and our own agency. And we see ourselves not as human first, but as whatever our pathology or medical condition or whatever that other thing is. And so in a way, I love what you're saying, because it's like giving people back their humanness.
And as I introduced myself, I mean, I'm a survivor of multiple ACES, a 2-time survivor of postpartum depression. And as a survivor of trauma, I feel like so many things were stigmatizing, and if somebody's acting crazy or communicating something that you don't understand, people look at that person and say, what is wrong with you? And I feel like in my practice as a nurse and a care coordinator, and I see everything in a level 1 trauma,
Yeah.
emergency department, all
Yeah.
different kinds of behaviors and things. But if you can kind of switch in your mind before you even interact with that person and not think, what is wrong with this chick? If you think, what happened to her?
Yeah.
What happened? It completely changes the vibe of and your ability to connect with the person.
I love what both of you just said, and I just want to add one little layer, which is that I think the same thing is true for some of the features of doctors and clinicians and people that are interacting with patients, where we feel like we have to be perfect and fix them. And that's protective for us. That's something that we get out of our medical culture, where we feel like we're not doing a good job if we don't completely save the day. And it short circuits this humanity, which is like why we wanted to do this. We want to be healers. And sometimes being a healer is just sitting with the person and receiving their human dignity and reflecting back to them that they're not defective. So I love that, because we can all shed the protective, not defective, in whatever role and whatever place we are, and open up to this transformation that you're talking about, that I can feel through the Zoom. Feels like a real thing that you're offering your patients.
Would you mind if real quick, I shared a quote about compassion?
Yeah, that
Go
sounds
ahead.
wonderful. It might be the thing that we end up closing on, because we have a few more minutes, and I think it would be a perfect note. So please do.
Okay. And this is from one of my, I just love Brene Brown.
Mhm.
So this is out of one of her books, but it's compassion is not a relationship between the healer and the wounded. It's a relationship between equals. Only when we know our own darkness well can we be present with the darkness of others. Compassion becomes real when we recognize our shared humanity. That's literally what you just said.
Common humanity. I love that. Thank you so much, Kimberly. Does anyone else have anything they want to add or share before we have to end?
Just as a reminder, you can all find the link to the slides that Brenda and Sarah shared today in the Whova app. And you can also connect with everyone who was in the session there via chat, and hope that you all enjoyed. And I want to say to Brenda and Sarah, thank you both very much again for your time and expertise that you brought here today. Thank you all for being here.
Yeah, thank you everybody for joining us.
It was really nice to see so many people and hear from some of you.